Yes, Shakti. Good evening, everyone. I welcome you all for our next Meet Expert webinar. And today we are coming back to neurogenetics. And today's talk will be on whole genome sequencing. I request your President Shafari ma'am to introduce the speaker for today, the experts for today's session, and the moderator for today's session. Over to you.
Thank you. And now at the outset, I welcome all of you, besides today's webinar, to the AOCCN, Asian Oceanian Child Neurology Congress, to be held in Yashbhoomi next year from 17th to 20th of September, and pre-conference workshops on 16th. And today we have our dear friend, Dr. Vinod Skaria, and he will be talking on converging genetic testing, the what, why, and when of whole genome sequencing. And we have experts. Can I have the slides, Asmita? Vinod is a very senior physician scientist who has been working extensively in the area of the genomics, and he has over 200 publications, and he has got numerous awards. And as experts, we have our Dr. Javeria Alvi, who's a faculty in pediatric neurology in Lahore and has special area of interest of neurogenetics, and Dr. Biju Hamid, who needs no introduction to us, who will be there to guide us and see, because of different resource settings, how whole genome sequencing acts. Besides this, we will be joined by Dr. Ratna Puri. She's a professor in genetics and chairperson, Institute of Medical Genetics and Genomics at Gangarang Hospital, and she's president of Indian Academy of Medical Genetics currently. And besides that, we have a very bright Dr. Kuntal Sen, who is co-director, Neurogenetics Clinic Center for Neuroscience and Behavioral Medicine, Children's National Hospital, Washington, D.C. And he has done both pediatric neurology as well as genetics. And his research focuses on multimodal neuroimaging and neuromonitoring in inborn errors of metabolism, and is a fellow of American College of Medical Genetics, and has lots of credits to his profession. He's a young budding pediatric neurologist and a geneticist. And the moderator is Dr. Juhi, our own alumnus, and currently a faculty in the Department of Pediatrics, SMS College, Jaipur, and has been the chair of FLICNA for the last 2 years. And Dr. Juhi, over to you. There is a slight change in the schedule. We'll have first two cases very briefly, and then we'll be having the talk by Dr. Vinod. Yeah. Dr. Juhi?
Thank you, ma'am, for introducing everyone. We'll begin with the case presentations. And my good evening to everyone, and to you, Dr. Mahesh Kamte, Dr. Biju Hamid, everyone, Dr. Zaveria. So we'll begin with the first case presentation right away.
You can invite, who are you inviting?
I think Dr. Zaveria is the second one to go. And to begin with,
Dr. Kavya.
Dr. Kavya.
Yeah, you can start sharing.
Yeah. So Dr. Kavya Rajrajan, who is from SRCC Mumbai, she will present a case under the guidance of moderator Dr. Anaita Hegde.
Yes. Good evening, everyone. Just opening my presentation. Is my presentation visible?
No, not yet.
Just double click on this presentation.
Is it visible?
No. Your slides are not visible.
Now you can share your screen first. The green button on your bottom of the screen, you have to just hit the button.
Yeah, I'm doing the same.
And then select the PowerPoint.
Yeah.
Yes, now we can see.
Okay. Good evening, everyone. I'm showing a genetic case today. I'll keep it short because of the time. So it is a 6 months old male child who was second born of non-consanguineous marriage with normal birth history, presented with some developmental delay. He did not attain head control, partial rolling over, palmar grasp, cooing, and social smile was there at 6 months. He brought with complaints of paroxysmal events, which started at 4 months of age, where he gets tonic posturing of the body, sometimes arching back with bilateral eyelid flickering and eyelid closure. At times, he cries at the end of the spell. It was happening in clusters. Initially, the EEG was normal, so they told to be dystonic spasms, but later which the frequency increased and the EEG also showed some intrictal epileptiform discharges. Hence, he was started on multiple anti-seizure medications. So when he presented to us on examination, he was alert, he was cooing, head circumference was age appropriate. He had intermittent fixing, tonic posturing, dystonia, chorea, and some dyskinetic movements, intermittent eyelid flickering, bilateral horizontal nystagmus, hypotonia, and DTS with 2+, no neurocutaneous markers. This is the video showing his horizontal nystagmus, and he had some rotatory component also, which we can appreciate in this video. So medical history, initially he was on anti-seizure medication. We tried tapering it off and we added oxcarbazepine. The reason I'll tell later. Frequency reduced to 1 to 2 brief episodes per day. 2 months he was events free. Later which he got fever with rash. Again he got multiple similar episodes for which he got admitted in nearby hospital where again they have loaded him with 4 anti-epileptic medications. He had some mild regression but he is catching up well now. So these are the events in the hospital where there's some tonic posturing of the body with eyelid flickering and some spasm like events where he flexes his body also. This is the recent one after the events where he is catching up very well. He is responding, he is fixing and tracking intermittently. So this is his MRI we did. So it is showing this is the T2 weighted image is showing white matter severe hypomyelination. Even the plic is showing hypomyelination, and the brainstem also showing hypomyelination. So which is a severe variety. And this is the same in T1 weighted, and even in the sagittal we can see there is hyperplastic corpus callosum in this child. So at this point we did his VEP, which showed abnormal, right eye prolonged response, left eye was normal. So we had a DD of like hypomyelinating disorder with developmental delay, hypotonia, nystagmus, dystonia, and choreoathetosis. So our first DD was X-linked recessive pelizaeus disease, and otherwise it's a PMD-like disease. So these are few hypomyelinating disorders that we know with all these representative like classic features of these disorders. So then comes the family history. This is the genes that we went through. I'll come to this later. This is the family history where the mother herself had global developmental delay and horizontal nystagmus with seizure-like events at 4 to 5 months of age, which got controlled with oxcarbazepine. So the grandmother accompanied the child and the mother during the visit, and she told us all the history. And she told the mother was exactly looking like the child in her 1 year of age. So after starting oxcarbazepine, there was no further events till 3 years of age. She caught up with her milestones gradually. She started walking at 2.5 years. Speech started at 3 years. She was put on school at the age appropriate period. Only thing she had some fine motor and coordination delay and some handwriting issues. Otherwise, no ataxia, no spasticity, nothing. So investigations happened at 6 months of age for the mother, which showed absent VEP, ERG, and absent BERA. She got operated for bilateral squint at 7 to 8 years of age. No follow-up further required actually. So they did not meet any doctors. But at 6 months of age, this is the mother's image, which is showing nystagmus, and this is at 1 year of age. So at 6 months, so this is the family history. So nobody else in the family got affected. They are basically Maharashtrian residing in Nagpur. So interestingly, the grandmother saved all the medical records. It was in 1991, so we could go through everything, and we could see Dr. Vadia's notes and his Dr. Rajesh Adani sir's notes and everything. So this is the MRI of the mother at 6 months of age, which is also showing exactly the same MRI as the child, severe hypomyelination. No other cerebellar atrophy or anything else. Severe hypomyelination was there. Later, when she grown out of it well, did well with academics. She required only writer for her slow handwriting concerns. She topped her 12th and she topped her B.Ed. She completed BA, MA, and B.Ed, working as a teacher now. Her CNS examination is completely normal except very mild squint. No other significant family history, and she has one normal elder daughter who is 7 years old. This is the handwriting of the mother at present. So we wanted to know what's her MRI picture right now. So we repeated her MRI. This is a recent MRI at 34 years of age, which is showing severe cerebellar and cortical atrophy. And also there is some hypointensity in the globus pallidus and the basal ganglia, which we discussed with our this is showing thin corpus callosum also. And the radiologists are two groups. One is telling it's accelerated mineralization. Other people are telling this is because of the relative hypointensity due to the hypomyelination. That's why we are seeing it more. So this is the MRI of the mother. In view of all this, we had sent whole exome sequencing of the baby, which showed a hypomyelinating disorder, TMEM106B gene. So this is the omum of that gene. So this has variable severity. So I'm getting it short because of the time. So mainly this gene causes lysosomal protein disorder and can cause multiple neurodegenerative diseases in the adulthood. But in pediatrics, in the recent times from 2017 to 22, these are the articles we could find. Not more than 8 or 9 cases reported so far. All of them had nystagmus, ataxia, hypotonia, and everybody had the same mutation in the same gene, C754GA. So this is the 6 cases that they have showed in the thing, and the last one is our case, almost fitting everything perfectly. So these are the MRI of the other patients. So the last one, HLD.
To the conclusion, can you come to the conclusion,
Yeah,
please?
so the take-home message is role of evolving genetics. The same mutation can present with varied clinical outcomes. Few hypomyelinating disorders are not as debilitating as we always think. So importance of preserving medical records. So thanks to Dr. Amarjeet Bhatt, he referred the case to us. Thanks.
Thank you, Dr. Kavya. That was a very interesting case. And we'll now invite Dr. Zaveria for the next case presentation.
You can, Juhi, you can ask for comments from the experts if anybody wants to make any comment. Dr.
Right.
Biju? Because Dr. Anahita is not there.
Interesting.
No, I am
Please, there,
sorry.
ma'am.
You there?
Interesting.
Dr. Anahita, is you there?
Anita,
Hi. Can you hear me?
Yeah. Please. Now we can hear. I can see you.
No,
Acha,
no.
your name was not flashing. Okay.
No,
Okay,
I
fine. You're there.
think
Please, your comments.
I'm in the
Yeah, you're
attendance.
connected.
No. From my side, we just wanted to highlight yet another gene associated with hypomyelinating disorders. The relatively good outcome of this child, I think the mom is paramount of that. However, though she's functioning well at the moment, her MRI is suggestive that she is most likely going to go into concerns going forward. And the last is the value of keeping the notes and the details and the MRIs, because that's how we clinch the diagnosis. Biju, I'd love to hear what you were saying.
No, interesting case, Anita, because particularly, when it comes to hypomyelinating leukodystrophies, we always think of Pelizaeus-Merzbacher and like Polar and TUB4A, etc. And this is I've never heard of this one. It's very, 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 very interesting. And particularly the two key things. One, certainly like the importance of detailed history going back at least like 3 generations. And the fact that like the prognosis, it's made a huge difference in this one, isn't it? Unlike the Pelizaeus-Merzbacher and the Polar3s. So interesting, very interesting case.
Yeah.
Hussain?
Yeah, I was going to say fascinating case and very well presented, Kavya. It seems like there's a strong resemblance with Pelizaeus-Merzbacher because of the early presentation and the nystagmus. I was wondering if that's what it is going to be, but yeah, it turns out to be another hypomyelinating leukodystrophy, and how well the mom has done is remarkable, showing that all these neurogenetic conditions come in a spectrum. Not all of them are debilitating. Curious, how did you find the variant? Was it a leukodystrophy panel or exome, or what was your test of choice?
Whole exome sequencing. We went through the genes and we also had a thought the newer one, but mainly we thought Pelizaeus-Merzbacher's, but we sent the whole exome sequence.
Because it was just hypomyelination, wasn't it? There was no definite pontocerebellar hypoplasia, were there? No.
No. So only severe hypomyelinating.
Yeah. So obviously,
I think when most.
before all,
Please.
you went straight to whole genome, isn't it? But I think that's the key thing, isn't it, in terms of differentiating between the hypomyelinating and perhaps the ALD, so the demyelinating. So yeah.
I think very important take home was, which was very nice, the records of the mom. I mean, that was very helpful. I think it's very, very important, and it's nice that you were lucky to have a patient who kept all the records and all. That is very good. And it's not that frequently. Very nice case and very well presented, Kavya. Thanks, Dr. Anahita. Juhi, we can move on to the next case.
Yes, ma'am.
I'll
So
ask
now,
Dr. Vinod if will be ready. Yeah, you get the.
so we now invite Dr. Zaveria Raza Alvi from Pakistan to present the next case. Dr. Zaveria, you can share your screen now. She is a pediatric neurologist at Lahore, and she's an active FLICNA member as well and a dear friend. So, Dr. Zaveria, over to you.
Thank you, Dr. Juhi. Good evening. Are the slides visible?
Yes.
Okay. So I'm going to present a brief case about a 4 years old boy who had a very fluctuating neurological course. So this 4 years old boy who had normal perinatal events and was born at term, developmentally age appropriate boy, had come to us with weakness of left side of the body, leading to gait difficulty for the last 2 months. And the parents also noticed that he was less fluent in speech than before. So in this video, when he starts to walk, you'll notice that he actually drags his left side of the body, left foot, and there is relative paucity of the left arm as compared to the right side. These features were not associated with any history of fever, seizures, vomiting, encephalopathy, visual or hearing issues, swallowing difficulty, or any eyeball or facial deviation, and neither any preceding history of viral illness. He is the fourth born child of four siblings, born to consanguineous parents, and his first male sibling actually died in the early neonatal period. The parents noticed that he had a difficulty in swallowing, feeding, and there was hypotonia and lethargy, but he expired undiagnosed. Then we reviewed the medical record of this child and we found a significant past history at the 2 years of age when there was an episode of right-sided leg weakness, which progressed to involve the left side as well, becoming paraplegic within 3 days with associated encephalopathy. At that time, even there was no fever, seizures, or any failure nerve palsies. He was admitted and treated as a case of physioencephalitis with the differential of Adam. His CSF came out to be normal. The neuroimaging report actually showed asymmetrical white matter changes bilaterally. Hence, the differential of Adam was also kept. And his cardiac profile protein CS was normal, keeping in view the neurological deficit to start with. He was started with acyclovir and steroid at that time, and he recovered during the admission in terms of touching his baseline conscious level again. And focal deficits and paraplegia recovered over the next 3 to 4 months, and he was completely symptom-free for the next 20 months until his 4 years of age episode. So this examination at the 4 years showed a conscious child now with only left-sided hemiplegic gait, 4/5 power, hyperreflexia and upgoing planters. Rest neurological and systemic examination was within normal limits. So keeping in view the previous history of neurological deficits with encephalopathy and now this episode with only stroke, and then the MRI report that was provided to us in the previous medical record showed white matter changes bilaterally. So we thought of the possibility of vasculitis, small vessel maybe which is coming again, or in a relapse of acquired demyelinating disorder, or some metabolic errors which is coming in with recurrent episodes like homocystinuria or MELAS. So we extended the workup further. And this was the baseline in workup along with homocysteine levels. It was normal. ANA profile was normal. The cardiac status was reviewed again and it came out to be normal. Acute phase reactants were normal. So these were the neuroimagings that we reviewed again that was done when he had his first episode in 2018. So these are the T1, T2 and FLAIR images, and all of these images have bilateral periventricular hyperrhital and periventricular peritrigonal lesions. And if you see on the FLAIR images, there is somewhat cavitations within these white matter hyperintensities. Here, there are subtle changes even in the midbrain, but rest of the cerebellum and other brainstem structures were normal. So this is the MRI which was done at this episode at 4 years of age. Again, these images showing bilateral white matter changes in the peritrigonal periventricular areas, and the cavitations has increased as compared to the previous one, and the bilateral cruras of the midbrain hyper intense signals have intensified in this one after 2 years. So keeping in view of all the history, we got a complete Euroaxis done. So the MRI spine, except apart from this midbrain signals in this sagittal view, was normal. The angiography was done to exclude any medium or large vessel involvement, which was also fairly normal. We had kept mitochondrial disorder also as a differential here. So we got the lactate levels, which came out to be high. The upper limit is 18 here. And we asked our radiology department to get the MRS of this kid. And with the block placed here, we can see the inverted double lactate peak at 1.3 ppm. Since we were keeping mitochondrial disorder in mind, so we had started him on mitochondrial cocktails also. And for confirmation, so based on the deficits with recovery in between, having an episodic nature with consanguinity and early neonatal death, leukoencephalopathy, high lactate levels, we had sent his WES also. And it came out to be positive for NDUFE1 complex 1 deficiency. So we continued the mitochondrial support with carnitine, coenzyme Q10, and vitamins with physical therapy and rehabilitation, and he improved with time in terms of only mild deficit in his left side. Currently, he is 7 years old. He has this deficit on the left side, but he's ambulatory with all self-care, going to school. He has some cognitive behavioral issues, but there are no seizures. The mitochondrial therapy is continued, and we have advised him for any sick day management if there is any. Mitochondrial complex 1 deficiencies, if we start from the case reports in 2012, they can be.
Praveena, the 5 minutes are over.
Okay, so it's just to highlight that they can be confused with acquired demyelinating diseases. Just like in this index case, it was done in the first illness at 2 years of age. But then when his second MRI came with these bilateral white matter changes of vacuolation, we thought that this is some mitochondrial problem that is leading to this. They can come with the episodic nature of the disease. And in the mitochondrial complex 1 deficiency, I would just add here that we have 12 patients with NDUFE1 that I all segregated. And out of them, 8 has a leukoencephalopathy-like pattern, which has come from 4 to 10 years of age. Only 4 had leak-like pattern and had a neonatal devastating events. Just like in our index case, the sibling died in the first month of life with hypotonia and feeding issues. So just to highlight that the advent of genetic testing has revolutionized our approach and has enabled us to precisely diagnose them. And MRI phenotyping had also helped us in such cases, because now when we see these cases on MRI, we start them on mitochondrial cocktail because genetics is not very readily available here. Thank you.
Thank you, Dr. Javeria. Juhi, you open for the experts to speak, but then Dr. Vinod will make the main presentation now after this. Open it to discussion.
Yeah.
He's ready with the presentation now. After the comments from Dr. Biju and Dr. Sen.
Interesting. Maybe Sangeeta has comments.
Yeah.
Does the diet work in this case, ketogenic?
So we haven't tried in this case. There was no seizures even to start with, but literature says, and we haven't tried it in this case particularly.
Yeah, maybe Sangeeta might have something to contribute.
Yeah, Sangeeta.
Nice. Yeah, good morning, everyone. Nice presentation. So, complex 1 deficiency is the most frequent complex deficiencies presenting in childhood. So it accounts for almost around 1/3 to half of the cases. So they usually have a very marked clinical and genetic heterogeneity. And the clinical presentation is highly variable. So they can present like a lay-like presentation. They can have leukoencephalopathy with cavitation as seen in your patient. They can have fatal infantile lactic acidosis. They can present with hypertrophic cardiomyopathy and exercise intolerance. So the clinical phenotypes are highly variable. So the imaging often gives a clue to the complex 1 deficiency because they have this predominant cystic leukoencephalopathy. So with regard to your question on ketogenic diet, even if you administer ketogenic diet, you will have increase in the acetyl CoA, so which enters the Krebs cycle, and when you have the production of the reducing equivalents, so it has to go through the electron transport chain for the synthesis of ATP. So when you have a complex 1 defect, I don't think it would be of high benefit to consider a ketogenic diet in these patients. So the cofactors may be helpful, but often it is not always successful with the supplementation of the cofactors as well. So very interesting patient.
Also,
thank you.
Sangeeta, in terms of what kind of mutation it is, would we be able to predicate on the prognosis in these children? as to what kind of
So
mutation?
complex one has got both nuclear genes as well as mitochondrial genes, and this is like one of the largest complex. As I said, like it accounts for around 30 to 50% of most of the complex deficiency care patients. So with regard to the phenotypic presentation, so again it has a variable presentation. So if some of them have like very early onset in the infantile age, they present with refractory lactic acidosis, and they often have mortality in the infantile period itself. Some of them have like a leukoencephalopathy with like a fluctuating course, which is seen in this patient, like episodic worsening with intercurrent illness, and they have like they can have like a variable course as well. So it depends upon the phenotype which they manifest with. Like some of them are like just present with an exercise intolerance, so they can have like a long lifetime expectancy, but some of them like they die often in the infantile period itself.
But depending on the mutation, the genetic mutation, like missense or nonsense or whatever, like, I don't know, like whether we can.
So maybe Dr. Vinod would be a better person to answer that. But if it is like in general, like if it is a nonsense mutation, when you have a stop codon mutation, your protein would be the quantification would be very less, and you often expect to have a severe phenotype. But I would like to hear from Dr. Vinod his opinion.
Before Dr. Vinod, would you like to say something?
Yeah, so if there's a truncation mutation, then yes, as rightly said, the severity of the phenotype is likely to be higher. And the truncation also, the effect of the truncation also depends upon what all domains have been sort of excluded out in the truncation mutation.
Yeah, and if I could just add to that, you could actually do electron transport chain studies on muscle biopsy or skin biopsy through a seahorse assay and see how much of the complex one is working, which can help prognosticate further. But very interesting case, Dr. Alvi. I was going to say, when you started presenting the case, the two other differential I thought of was ATP1A3, which leads to alternating hemiplegia, and pyruvate dehydrogenase can also present with episodic weakness and encephalopathy. But with the family history and consanguinity, a recessive disorder made more sense. And again, it just shows that all these disorders are so highly variable that a broad test like whole exome is the way to go.
Yes. Thank you.
Nice case, Javeria. Thank you so much. I think now we are going towards whole genome. So, and here comes our go-to person, Dr. Vinod Skaria.
Thank you very much, and hope I'm audible.
You're all good.
Hope my slides are visible also.
On the way. Not yet. Perfect.
Yeah. Sure, thank you very much, and my sincere apologies. My background is forest, and in fact, I'm in the middle of the forest. Just joking. I messed up the session, and I'm really sorry for keeping you waiting for this. So in next 30 odd minutes, I will sort of delve deeper into how we think the genetics or genomics is converging. And one of the ways genetics is converging is to use a much broader test, which is WGS. I will just discuss probably two examples and also two technologies that are sort of emerging and why they're emerging, and how, for a resource poor country like India, how can we rapidly adopt the benefits of whole genome sequencing. Now, to give a brief background of what I'm going to talk about is largely in this particular slide. I'm sure every one of you would already know what this is. This is a CT scanner invented almost 50 years ago. And to give perspective of how CT scanners have actually changed the perspective of modern medicine is that before this, used to have exploratory laparotomies to actually open up the human body to figure out what is really inside there, or what's the real pathology inside there. Now, CT scanner is revolutionized for the first time that clinicians can peek inside the human body without having to open it up. And very recently, to be exact, just 20 years ago, we have a technology where we can not just peek into the human body, but actually peek into every one of the 37 trillion cells in our ability to sequence and understand the human genome. And it took quite amount of time, quite amount of money to be able to sequence a human genome. But then, of course, in the last 20 years, it has actually become democratized that we are already talking about whole exome sequencing and whole genome sequencing in clinical meetings. Now, of course, India was not far behind. We had our first genome sequenced, analyzed, and reported in 2009, the 7th country being able to do that. Now, I'll stop there and sort of take a bit of glimpse into cases which has come across us and why we think this technology is very important. Now, this case was referred to us by Professor Shefali Gulati and Dr. Madhurika Kabra, 9-month-old baby with very characteristic symptoms suggestive of mitochondrial genetic disorder. And since we were the only lab at that point in time which were doing NGS for mitochondrial genetic disorders, it was referred to us. We did sequence the mitochondria, and we did not get anything. Well, we were perplexed, but of course, there is enough literature to suggest that mitochondria could be perfectly normal in mitochondrial genetic disorders because there are a significant number of nuclear genes which are also with mitochondrial function and could cause mitochondrial disorders. So we did a whole exome sequencing. We analyzed the data and we got nothing. Now, this was the second pregnancy for this family, and the family was very curious. So we were at loss of words because we really did not have any answer to what the family did have. So that was also the time when we were sort of piloting a whole genome sequencing in clinical settings as part of the Guardian Consortium. And what we did was to sequence the whole human genome. And in this particular assay, what we sequence is all the 3.2 billion alphabets. Of course, we could map around 2.8 billion of those 3.2 billion alphabets. The rest are in repeats, which cannot really map. But once you really map a whole genome sequencing, you could identify many more genetic variations what whole exomes cannot identify. And this is, in summary, what the genetic variation is. The parents have a heterozygous deletion encompassing multiple genes, ELUVL7, ERCC8, and NDUFF2, out of which NDUFF2 is of mitochondrial function, ERCC8 is a DNA repair protein, ELUVL7, we don't really know what it does. So now what do we really do? Of course, you could go back and do mitochondrial assays. That's what we did. I'm not going to explain that. But in simplistic sense, you could use whole genome sequencing to map the genetic deletion, establish the pathogenicity of this deletion. So this is in summary, this is the father, the mother, both of them have heterozygous deletions, and the child has a compound heterozygous deletion, which looks like a homozygous deletion because there's an overlapping region which is shared between two of these deletions. We actually went ahead and did prenatals also on whole genome sequencing for this particular child. And to make the sad story really happy, today this family has 3 normal children, normal healthy children. And that's largely possible because we could make a diagnosis, we could offer genetic counseling, we could offer prenatal testing, and they could identify the fetus, which is perfectly normal. So summary number 1, whole genome sequencing can identify many number of diseases which are apparently missed in traditional ways of testing. And in many ways, families do not have probably the time, effort, and the energy to go through multiple different kinds of tests. Now, this is another family. This is from Calicut, my alma mater, from Dr. Geeta Govindaraj's clinic. Now, this family came to us just by accident because there were 2 individuals with apparently similar clinical features who were also admitted at the same point of time, but apparently did not know that they were related to each other. But of course, since the clinician was very curious and eventually they realized that they're relatives, they wanted to explore this much further. We did an exome sequencing. And of course, before that, this is a clinical summary of this. This is a primary immunodeficiency disorder, typically suggestive of an X-linked agammaglobulinemia, because typically males are affected, it's X-linked. We did an exome sequencing, we did not get anything. And we did a whole genome sequencing. And the whole genome sequencing, we found a particular small deletion encompassing 3.5 odd exons of the BTK gene. Now, by close follow-up, this family, Dr. Govindaraj did draw an extended pedigree. Many families, or many members in the family, extended family, also did have the same clinical features of XLA. They were also, some of them were also tested for whole exome sequencing. They all had negative reports. So we recalled the exome sequencing, put them into the context, and we realized that all of these samples do have the deletion encompassing around 3 exons. Now, this is where whole genome sequencing can identify deletions in cases where they're missed out in a traditional whole exome sequencing paradigm. Now, if you ask this question, is whole genome sequencing better than whole exome sequencing? Of course, there is data to prove that from, of course, studies across the world. And we have also data from India, at least for one genetic condition, cardiac channelopathies, where we have extensively looked at a large cohort of cardiac channelopathies. We looked at exome negative cases, and doing a whole genome sequencing, what we show is that we could add almost 12% additional positivity to whole exome sequencing, especially when performed in a cascade screening approach. This was published, of course, this year. So what I'm trying to bring to point is that today we have a multiple variety of genetic tests, which ranges from karyotyping, FISH, RACGH, chromosomal microarray. You have MLPA. For repeat expansions, we have repeat PCRs, and of course, the repeat expansion disorders have grown in numbers in the last half a decade or so. Then we have small deletions, large deletions, which we do MLPA for. We have sequencing of single nucleotide variations, either by doing a panel sequencing, a clinical exome, or a whole exome. For mitochondria, we have a mitochondrial genome sequencing. So we have a variety of tests, and we especially spend our time, energy, and effort to try to navigate through these tests, try to interpret these tests. And each of these tests comes with its own turnaround times, its own complexities of analyzing and reporting, and its own caveats of what it can report. But now think that these are all genetic tests in one aspect. So if you could just sort of converge this into one single test, which is today faster, cheaper, and in more ways more effective in terms of diagnostic positivity, can we replace all of this test with one single test? And I think that is possible today, and that's what whole genome sequencing is. Now, the second aspect that I'm going to bring to point is that now when we talk about genetic diseases, we talk about rare genetic diseases. And in many ways, these diseases are not really rare. And that's the only learning that I have from working almost a decade and a half in rare genetic diseases. But the real question is that then why are these genetic diseases not very prevalent? Why are they not being captured in clinics? And to me, that is largely because of a gap. And this gap is largely the education, awareness, and the availability of the diagnostic. Now, how do we identify the gap? The answer is very simple. You could sequence apparently normal individuals in the population, look at the heterozygosity for pathogenic variations, model the prevalence of homozygosity. And if the homozygosity in a particular region really is larger than what is really captured in the clinics, that means that that's a gap. And you could identify and close that gap by offering a very cost-effective diagnostic test. Now, of course, this is very simple to talk about, not really really great to sort of put in practice. So until 2019, we did not have an opportunity to do this. In 2019, we had the first pilot population scale programs from India, which included around 1,028 whole genome sequences from cosmopolitan populations across India, where we could look at treatable genetic disorders, genetic variations which are prevalent in the population for recessive genetic disorders, look at cancer susceptibility variations. And what we found from this particular data set was really stark, is that approximately 1 in 20 do have a clinically actionable genetic variant. And these are, mind you, adults, not children. Now, to put numbers, 1 in 20 means approximately 5% of individuals, out of which around 2% would have a hereditary risk for cancer, 2% would have a hereditary risk for cardiovascular diseases, including familial hypercholesterolemia, cardiac channelopathies, and cardiomyopathy. Now, the rest 1% is the rest of all the genetic diseases put together. Now, just imagine if adults would have 1 in 20 kind of a genetic prevalence, what would children have? And of course, we don't have yet data from India on newborn children whole genome sequences. There is data from population scale, large scale newborn screening programs from around the world, including the much recent Guardian program, which was published a few weeks ago, which sort of suggests that approximately 3.7% of individuals do have a clinically actionable finding. Now, when we talk about whole genome sequencing, the other additional thing that we get in whole genome sequencing is our ability to predict how drugs affect or how drugs work on the human body. And this is the area what we call as pharmacogenomics. It's very well documented that there are different classes of drugs and they have different efficacies across global populations, though while they have been trialed all in a single population and they have all found to be effective and less toxic in that particular clinical trial. Now, when we talk about pharmacogenomics today, there are guidelines. There are around 70 odd drugs for which pharmacogenomic guidelines are currently available. And many of these variants are indeed very prevalent in India. This includes very frequently used neurological drugs, like, for example, carbamazepine and phenytoin. You could have, for example, anti-HIV drugs like abacavir. You could have allopurinol, very, very frequently used and very frequent pharmacogenomic variants in the Indian populations, all based on the genetic frequencies that could be available in the population scale database. So in other words, what we can also suggest is to say that population scale databases can provide very useful clues into prevalent genetic diseases, but also provide very useful clues into accelerating precision medicine by looking at very prevalent actionable pharmacogenomic variants for which you could build in very cost-effective test at a community level. And to put numbers, of course, every individual in the indigenous cohort had an average around 8 clinically actionable pharmacogenomic variants based on today's guidelines. And today's guidelines is largely based on the FDA drug labels, the CPIC guidelines, and of course, the Pharmacogenomic Implementation Consortium guidelines out there. Now, I talked about how we can sort of close the gap by offering genetic testing. And this is what we tried in one of the centers in Kerala. This is Calicut Medical College, led by Dr. Geeta Govindaraj, who runs a PID clinic there. And the idea of starting this cohort and this clinic was essentially that we did find a huge gap in the prevalence, or the genetic prevalence of primary immunodeficiency disorders and the actual prevalence that is documented from the hospital. Now, if there is a difference in the actual prevalence and the genetic prevalence, that would necessarily mean that patients are not being diagnosed. And if you could, the hypothesis was very simple, that if you could offer them a very specialized care plan in terms of diagnosis, in terms of molecular confirmation, and in terms of genetic counseling, you should be able to identify many more children and be able to treat it, because primary immunodeficiency disorders are largely treatable conditions. With a curative intent, you could do a hematopoietic stem cell transplant, or some subclasses of primary immunodeficiency disorders, you could have a perfectly normal life with immunoglobulins. And with support from the state government, support from NGOs, and a grant from SCRB, we sought out to create a very specialized treatment plan, a clinic, and testing that's available locally at the hospital for the very prevalent genetic disorders which were mined out from the population scale data. And over almost half a decade, we have built it to one of the largest primary immunodeficiency cohorts in this part of the world, probably the second largest in Asia, except for Hong Kong. And this has enabled multiple patients to access curative intent therapy, which is a hematopoietic stem cell transplant, all funded by the government, and a much larger number of people who could access genetic counseling and prenatal testing and prenatal screening. And given the high prevalence of these disorders in the population and that they are curative in therapy, we could sort of roll out a pilot newborn screening program, and that is something that is in process, and probably early 2025, we would be probably one of the first centers to roll out a pilot newborn screening program for primary immunodeficiency disorders. Now, of course, when I talk to people about whole genome sequencing, I've done that over the last 2 decades. The first question is, who can really afford a whole genome sequencing? And that is really true, because compared to a whole exome or a clinical exome panel, a whole genome sequencing is approximately around 6x in cost difference. Now, in a population where, like India, where there's a huge disparity in income, it's very understandable that not all people can afford to have a whole genome sequencing, and probably of the patients, less than 2 or 3% would be able to afford a whole genome sequencing. But does it mean that the benefits of whole genome sequencing should not be given to patients? The answer is probably no. And that is where we sort of looked at technologies which can sort of build the best out of both. And one of these technology that we have recently implemented is what we call as a blended genome and exome. And the idea of this is very simple. You do an exome sequencing to look at exonic nucleotide variations. You do a whole genome sequencing largely to cover other genetic variations which are not covered in a whole exome sequencing. This includes chromosomal structural variations, copy number variations, mitochondrial genetic disorders, and also intronic variations which might be missed out in a whole exome sequencing. Now, what if you could merge both of them? Not merge as in a 1-to-1, but something like a 5x of a whole genome sequencing, which can capture pretty much everything that you want to capture and replace the other tests that you are used in a cascade genetic screening, but also use a 100x or a 300x WS, depending upon the case scenario you want to look for. For example, somatic variations in autoinflammatory diseases can be captured on a 300x WS. So you can blend both of them into one single assay, and that is much cheaper than actually doing a whole genome sequencing. So we have been able to do this, and the idea is very simple, that you can get the best of both of a whole exome and a whole genome sequencing while making it accessible and affordable to a large number of people. And to put numbers, this is approximately just 1.5 to 2x the cost of a whole exome sequencing today. Now, of course, we have some early data for this. I'm just presenting one of these data sets. And this is one patient which was referred to us from the Amrita Institute of Medical Sciences with an autoinflammatory condition. Of course, the exome was negative, but then, of course, closely looking at the exonic coverage, which is a manual process at this point in time, we realized that there is some probes which are not captured on the whole exome sequencing. So we went back to the clinician suggesting that this is something that we need to look further. We did a BGE, and what we show here is that we can exactly map the breakpoints of the deletion and sort of confirm this as Majeed syndrome because that involves a gene that is involved in the disorder. So at pretty much double the cost of a whole exome sequencing, you can map accurately the breakpoints of the deletion and be able to come to a molecular diagnosis. So the advantage of BGE being that it covers best of both. WS is a capture-based approach which introduces a PCR bias, and due to this PCR bias, copy number calls are not very accurate. But nevertheless, it gives an advantage that gives a very large coverage across exonic regions, and therefore, since almost 60 to 70% of all pathogenic variations today reported are in the exonic region, we could capture them very effectively. But the WGS can cover actually the entire genome, and the uniform coverage being a PCR-free approach can be very usefully used to look all copy number as well as structural variant calling. So it is blending both of it. Now, where would you use it? You would have use it when you are using a WS plus MLPA, you're using a WS plus chromosomal microarray or an array CGH for a chromosomal duplication or a deletion, for example, in autism spectrum disorders. Where you use mitochondrial genome plus WS, especially for a neurological condition where you suspect a mitochondrial genetic disorder, you would want to look for mitochondrial mutations as well as the nuclear encoded mitochondrial gene mutations. So in such situations, you could essentially do away with doing two tests, but rather do one single test, which is essentially a BGE. And of course, you have many other applications in research domain, which includes imputation and replacing arrays, using germline allele frequencies for population scale studies, and so on and so forth. So in summary, it can offer clinical diagnosis, mapping copy number variations to chromosomal abnormalities, structural variants, and any resolution. It covers the introns, which are not typically covered in WS, so you can look at pharmacogenomic variants. It covers the mitochondrial genome, and therefore you can also look at mitochondrial genetic variations without having to do an additional assay. And of course, it also has research applications. Now, before I close my talk, I think there is another convergence which is happening. And this convergence is happening largely because of the drastic reduction in the cost of sequencing that has been happening over the last 2 decades. To put in perspective, what you see in the y-axis is the log order of the price reduction compared to the x-axis, which is over the years. And we are probably at the right point in time when we are at the inflection point where WGS is replacing WES as a first line of testing for many complex genetic disorders. And that's largely because over the time, we expect the prices of WGS to be fraction of the WES that we use today. And at that point in time, we think that there'll be widespread adoption of WGS for genetic testing, not just for newborn disorders, not just for neurogenetic condition, but also for apparently normal adult individuals. And the reason why we think that this is going to create an inflection point is because of the fact that the way we use genetics or genomics at this point in time is in a reactive mode. In other words, you expect the patient to come to a clinician with a set of signs and symptoms, probably with developmental delay, and the clinician does a clinical workup, draws a pedigree, and you use genetic sequencing to confirm the diagnosis. But in many cases, as you would likely imagine, the process of genetic diagnosis by itself is time-taking and time-consuming. Of course, the time slot has really come down over the many years. But the real opportunity is where you can really put it proactively. In other words, you can put a genotype-first approach, look for variants where we have evidence for treatment. And if you can have an evidence for treatment, you can actually treat and actually ameliorate the condition even before the patient comes to the clinic. Now, there is nothing new in this because this is something that we do in a biochemical test, and that is what we call as a newborn screening program. And in newborn screening programs, we typically use biochemical tests. The largest panels that are available today is in the US with around 37 odd genetic disorders. And the idea is that you look at prevalent, penetrant, and variants with actionability, which are treatable. And of course, by doing a whole genome sequencing, you can cover many more than 37 disorders. To be exact, today we can cover around 156 odd genetic disorders, which are treatable or manageable. And this is not something new. There are many countries who are already doing a genomic newborn screening program, either in a whole exome sequencing or increasingly on a whole genome sequencing, including the Generation project, which is just announced in the UK. So to put numbers, this would necessarily mean that one in around 182 newborns would have an actionable genetic variant. And this indeed is an underestimate, but if you really go back to the Guardian paper, you would realize that this is approximately around 3.7 or 3.9% of children who would have a clinically actionable genetic variant. Now, that would also mean that you need to have a living genetic report because the impact over the lifetime of the individual is something that, that is going to change over the time. There are new genetic variations which are being discovered over many years. The pathogenicity of genetic variations which change over time. And then therefore, that would mean that while the genomic sequence is constant from the day you're born to the day you are dead, there are different points in time you would want to look at very different kinds of questions, or clinicians would want to look at very different kinds of questions, or you would want to have therefore a living genetic report which spans your entire lifetime. Thank you very much. But before that, there are a few take-homes that genomic sequencing is becoming really affordable for routine clinical implementation, and that is indeed a convergence of all genetic tests into one. Genome sequencing at an individual level can enable disease diagnosis at an unprecedented scale with a significant increase in the positivity. And at the population level, at aggregated data can indicate very prevalent genetic diseases that are probably missed out in routine screening tests. Genetic diseases are extremely prevalent. Approximately 1 in 10 individuals would have a genetic disease, and therefore genomes are for everyone, not just for pediatric population, but also for adult population. And since genomic evidence is for a lifetime, you need to also rethink the way we report genomic sequence, because we would need to have living genomic reports. Thank you very much.
Thank you, Dr. Skaria. Dr. Juhi, I just wanted to say that Dr. Ratna has also joined. She's a very senior geneticist. So from a physician scientist, a dear friend, to go to another friend who is a geneticist before you come to the pediatric neurologist. And then we have a combo of a pediatric neurologist, geneticist also there. Dr. Ratna?
Yeah.
After the amazing talk of Vinod, your take on that. Yeah.
Yes. Thank you so much, Dr. Vinod. It was an amazing talk, as always. I don't know, for some reason my video is not working, but it's fine. And, you know, Shefali, first I'd like to understand if there are questions from the audience, just to get a sense of how they envisage that this technology can be used. It is amazing technology. And I know in India, I mean, at present, we are using it sparingly, except for in a few centers. And I totally agree with what Dr. Vinod has said, that a convergence is required. But we also know that in our current scenario, we have challenges even with exome sequencing. And I'm sure Dr. Vinod also is aware of it, and all of us are, about the quality, the depth. And what I always tell every clinician, it doesn't matter who orders the test, but it's important to understand what is the question we are asking. And if the company knows that we understand the technology, they will be careful. And I think that's very, very important. And the reason I say that was that in the undiagnosed diseases program, which we ran in the country, and we first re-looked at all the exomes that were available in the children who were recruited, children or adults who were recruited in that program before we did genomes. And we had a diagnostic yield of 27% just from reanalysis of that. And yes, and then from the genomes, it was about 37%, but that was because we did a very small number. We had only done 100 genomes. And I'm sure the percentage will come down compared, because it was a very distributed cohort. It was not a specific cohort. And even in the specific cohort that Dr. Vinod presented, it was 15%. And that's what is known, that a genome increases your yield by 10 to 15% because of various things that he has presented, the copy number variations, or the deep intronic variants, or we've even identified those moving, jumping genes, or what you call the mobile element insertions, etc. So there are great advances. And I think now we are in a time where in our respective specialities, everybody has to keep updated with this. And I think it was an amazing overview which Dr. Vinod gave, how the technologies are converging. Like triplet repeats, you can pick up from a genome. You don't, if you have ataxia, you don't order all the SCAs. If you're suspecting spinocerebellar ataxia, you don't have to order the host of SCAs, but yes, in the genome, we can identify all that. So I think that's essentially just the few words that I want to say. And then, of course, depending upon what the queries are.
Sure.
I think
Dr.
there's
Biju?
one about a variant of uncertain significance Shefali, Dr. Vinod, would you like to
questions.
answer that?
Questions will be asked. Actually, we ask the experts and then Juhi will go through the questions.
Yeah, okay.
We're just asking one comment from
Sure.
the expert in the
Sure.
Yeah. Juhi, you can ask all the experts. You can ask Biju, Dr. Sain, Dr. Javeria. Dr. Biju?
Yeah, thanks, Vinod. Fantastic talk as always. Yes, absolutely. I completely agree with your points. Now, in practice, what we are finding, you know, as pediatric neurologists, like often we are at a loss to try and give the and I asked for like what is the question that you are asking the geneticist. But often in the busy clinic setting, often that's very difficult to do. We are actually at fault in terms of like, you know, finding the easy way out and just requesting whole exome or whole genome, whatever. But in terms of undiagnosed diseases, what we are now finding or sometimes adopting in practice is reverse phenotyping. You get the results first and then you go back and then dig deep. And to some extent that certainly yields results. I would be interested to know what are your thoughts on that in terms of that reverse phenotyping approach with genetic reports.
Thank you, Dr. Biju. And I think that's a very, very pertinent point that you have sort of raised. And in fact, in our daily life now that I've moved out of academic into a sort of research and clinical setting, reverse phenotyping is something that today we advise practically almost 30 to 40% of our reports, because we do have a call with the clinician on practically every report. We go back to them and sort of ask for additional questions, because doing a broader testing always gives you additional inputs and additional things that you might want to really go back and look at. Like, for example, even today I have a family with an ataxia, which was not documented in the genetic counseling notes. But then, of course, we called up the clinician and the clinician is calling up the patient. On phone, we today know that extended family has ataxia phenotype. So yes, reverse phenotyping is something that is absolutely important and essential on two ways. One, it would be an educational endeavor, because we will get to know what variations are causing what phenotypes. Second, it makes us very humble and appreciate that a genetic variation can indeed create multiple different phenotypes in multiple individuals. Because the traditional way of looking at genetics is that I have a phenotype and therefore I have to have this genetic variant. Now, by identifying genetic variants preemptively, we also, in phenotyping, realize that there is a wider spectrum of phenotypes that can be caused by a single genetic variant in an extended family. And I think, somebody who has been a student in genetics, this is extremely humbling.
Thanks, Dr. Vinod. I just had one question to alongside what Dr. Ratna suggested. I don't know whether Vinod, you probably know, like G42 is now planning to roll out newborn screening for 677 genes, and the list is increasing. This is in the Department of Health in the United Arab Emirates. And then we were having a little discussion, and then the question of Fragile X came up. So that was what Dr. Ratna was also suggesting. And this question of whether Fragile X should be included in the newborn screening, this debate's been going on for at least for the last 10, 15 years. I think the jury is still out on that. So my question was in terms of the yield in repeat testing, in those conditions, do you think like the time has come to include, obviously there's a rationale for including Fragile X, isn't it? It's a clinical rationale, but has the time now come to include those sort of conditions? Or are we still, in terms of long reads and those repeat ones, like are we still further away from it?
Yeah, I think that's a very, very pertinent question. And I have a very drastic view on this. Okay, and the view on this is very simple. And I'm sure this is going to irritate a lot of people, right? The decision on what to test in a newborn screening program is going to be locally determined, because that is largely dependent upon the genetic conditions which are treatable by the healthcare system in that particular country. And these are going to be very different in very different countries. Now, let us not really compare India, which has a per capita GDP of around $2,000 odd, to, for example, Qatar or UAE, which has probably $40,000 or $20,000, right? The conditions which are treatable in those economies could be very different from the conditions which are treatable in a country like India. So we need to have a very nuanced view of what needs to be reported. And there is never going to be a global standard on it. This is only going to be a local standard, because to me, it is probably unethical to tell a parent that I have found a genetic disease which is not treatable in a newborn screening program, right? And I think I'll leave it there.
And that's absolutely true.
Yeah, if
Dr.
I can
Sen, what
say
do you want?
something, if I can just say something, I think that's very correct, because we are moving from the basic definition of a screening program, especially in the newborns. And I feel that the scenario in India is so different because there is a lot of stigmatization against women. And so when we even counsel in the clinic for X-linked disorders, it's very challenging to tell the family that it has come down from the woman. We probably do it the other way, that, you know, it's important to test the girls, because tomorrow we want to make sure that your daughter does not have a child with this disorder. So therefore, just to roll it out as a general screen is not a good idea. And I 100% agree with Dr. Vinod that it has to be what is local, because it's not a test, it's a program. We don't have systems of follow-up. We don't have systems of counseling. And the day we get thyroid, I keep saying universal thyroid testing for everybody in our country. That's the time when we are ready to expand to anything else, but not before that.
Absolutely, because so screening is to screen and pick up somebody to start giving the management. If we are not having management, you can't ethically do it.
Yes.
Dr. Sen, when you went from Mumbai to DC, so would give both the scenarios?
Yeah. I wanted to congratulate Vinod again. Excellent talk. You covered the nuances of genome sequencing versus other next generation sequencing very well. I had a few comments and questions. I'll start on the newborn screening front. I completely agree with Dr. Skaria and Dr. Puri. Even in a high resource setup like the US, some of the programs that used exome sequencing and genome sequencing for newborn screen, they encountered a lot of issues. So for example, you noted BabySec and North Carolina Nexus, who were using exome sequencing on all babies. They encountered a big issue about how to counsel for adult onset conditions which don't have a treatment, pharmacogenomic variants, so on and so forth. Because historically, newborn screening has been an opt-out rather than an opt-in test. So when they get the heel prick, parents aren't consented. They just get it unless they specifically ask not to get it. But if you're doing something as extensive as exome, you have to consent it. And these programs realize they don't have the bandwidth with geneticists and genetic counselors to do that consenting. So even in the US, it's been a similar experience. But otherwise, your talk was excellent. And I think you covered the different nuances of what's covered in genome very well, like triplet nucleotides and intronic variants and mtDNA. So it's definitely the way moving forward. The couple of questions I had. So in the US, we have something known as secondary findings, which is a list of 79 genes nominated by the American College of Medical Genetics, focusing on adult onset cancers and cardiomyopathy. And that's also an opt-in or an opt-out kind of a situation. So I'm curious to know, Dr. Puri, Dr. Skaria, how do you handle that in the clinical setup in India? And my other question was, in a lot of my exome negative cases, we are doing RNA-seq and long-read sequencing. Those are two other technologies which have come up here. I don't know if your group or any other group is in India is looking into that.
Puri, would you want
Dr.
to?
Vinod, you'd like to comment first?
Yeah, sure. So your first question was, I'll go from the last question, the long read sequencing. So the long read sequencing are largely for two indications, either for copy number structural variations or for repeat expansions. And what we show is that a low pass whole genome will cover both of it at a much lesser cost compared to a long read sequencing. Long read sequencing is actually much more expensive than an exome sequencing. The last but one question, I believe, was how do you handle
secondary findings?
How do you handle secondary findings? So for all of a WGS test, pre-test and the post-test genetic counseling is mandatory. And we do explain what are the different features that we sort of report in the report and in the WGS report. So broadly, we report 4 things, and in some cases optional, many more things. The 4 things that we operate is, what we report is first, the variations that match the clinical indication, if there is a clinical indication. Second is the carrier status of the individual. Third is the incidental findings, right? And fourth is the pharmacogenomic findings, right? Then there are optional questions that we sort of answer. This includes the HLA. For example, we get a significant number of patients who come for a genetic testing before a bone marrow transplant. So we do report the HLA and also the rare blood groups, because those are implicated in the prognosis of the bone marrow transplant. So in our experience, now have done quite some number of WGS, we have not come across a significant number of people in India who would opt out from incidental genetic finding. Right? To put numbers, it would be less than 1%.
Yeah, I also agree with what Dr. Skaria said. And there are centers who are doing long read, but basically academic centers. And CDFT has, and I think CCMB has. And RNA-seq is happening in many places. It's happening in many places. So these are really to sometimes confirm deep intronic variants. You know, the phenotype matching is great, but some of the phenotypes are so non-specific, like developmental delay, DEE. And so when you get these WOOS variants, I don't think it's a good idea just to accept them unless we do some further studies. Because there have been patients, phenotype match is very easy for these non-specific, unless there's really a good handle. And then you realize 2 years later, there's a new gene that has been flagged off for the patient, where you have, you know, phenotypically without further studies correlated a WOOS variant.
Just to add one more point, RNA-seq is indicated in a different spectrum of genetic conditions, especially in oncology, hematological malignancies, where you're going to look for fusions, and where it's a state of the art to actually do an RNA sequencing to identify them.
Great. Yeah, thank you. Yeah, and I also wanted to thank Dr. Gulati for organizing this. I think ultimately one of my philosophy is we need to bridge the gap between pediatric neurology and medical genetics. So I'm so glad that this is happening for the Association of Child Neurology India, because we are the ones who are seeing the children seize daily or suffer from dystonia. So we have to collaborate with our medical genetics colleagues to expedite testing, do the right type of testing, and tell them the right phenotype so that the variants in appropriate genes come to the surface. So bridging the gap between medical genetics and pediatric neurology is one of my main philosophies. So I'm so glad this webinar took place.
Yeah. I think we'll move on to the questions by the participants. So we have a question by Dr. Sangeeta Yoganathan. In patients with mitochondrial DNA mutations to determine the heteroplasmy, would you recommend testing in samples including blood, urine, and saliva in all cases? And as muscle sampling would be invasive, can skin samples be an alternative to the muscle samples? And how do you determine the threshold effect for mitochondrial DNA mutations for different tissues for a newly described variant?
So this is a very interesting question, and the answer to that is largely determined by the severity of the clinical phenotype. And the idea of different tissues is that each of these tissues come from different 3 layers in the developmental program. So you have ectoderm, mesoderm, and the endoderm. Blood essentially represents the mesoderm. The ectoderm is represented by the skin, and the endoderm is represented by the bladder epithelium. Now, if you, for example, have a child with a very severe neurological disorder and you see a very significant number of cells in the body to have that particular variant, then even testing blood is sufficient enough. You might not want to really do a muscle biopsy. Now, if the disease is very less severe and you expect to have only few cells in the development program to have that particular genetic variant, it's largely from the clinical assessment, then you could do any of the either ways. Now, in terms of heteroplasmy cutoffs, I think what is internationally approved is around the 13% cutoff, if I'm not really wrong. Of course, Dr. Puri can add to that. And there is no, I think, any reported clinical report of a mitochondrial genetic disorder with a heteroplasmy less than 13%.
Okay. The next question is by Dr. Ranjit. He says, excellent talk, Dr. Skaria. And what is your advice for pediatric neurologists when we have a trio whole genome sequencing negative, MRI negative epilepsy patients? In fact, 10% of all infantile spasms fall in this category.
Yeah, so this is not very uncommon that you have a genome report which is negative, and that doesn't mean anything. It doesn't necessarily mean that you don't have a genetic disease. Just reanalysis of a genetic data over time, and we have done that in the past. 3 years later, reanalysis would increase the positivity by around 8 to 10%. That is just because new genetic diseases and new genetic variants are being discovered and being added to literature. And as long as we can go back and reanalyze in a very systematic fashion, we would be able to, over time, be able to get much better positivity.
Okay. And one participant has asked, what is ultra sequencing? I am not sure about this term.
Must be asking for ultra rapid, or is there something like ultra? I don't know. Dr. Skaria, is there something like ultra?
Yeah, there is an ultra rapid sequencing.
So ultra rapid,
and ultra rapid,
but not an ultra, not an isolate.
So, yeah, when we talk about NICUs and newborn genomic screening in NICUs, there is an increasingly used concept where you can rapidly sequence a genome in less than 24 hours, 24 to 48 hours, and less than 1 week. So rapid sequencing is something less than 1 week. Ultra rapid is anything less than 48 hours. And this is today available in India for neonatal ICUs.
Okay, okay. Thank you, Dr.
Yeah,
Skaria.
but the cost, one second, but the cost is very high, right, Skaria?
Yeah,
Do we know? Because I know the company is giving it, they came up, but the cost is really huge when it becomes ultra rapid.
Yeah, so I completely agree that the cost is on the higher side, but having said that, we should also imagine that every single day of the child in the neonatal ICU is also going to cost as much, right? We did do this economic calculation to realize that even if we save 1 day of the child's neonatal ICU stay, you have pretty much recovered the cost of the test, right? And we have in the past experiences where we could reduce very significant stay in the neonatal ICUs. Of course, we hope to come back with a publication on this.
Right. Should we move on to the cases, ma'am?
Yes, we moved on to the cases, and please stick to 5 minutes. We have to finish off the 9:30.
Okay.
Yeah, call the next person.
So, Dr. Amresh Roy, are you there? You can start to share your screen. Dr. Amresh Roy from Indira Gandhi Institute of Child Health, Bangalore, under the guidance of Dr. Vaikunt Raju. If he is not there, I think he had joined earlier. We can move on to the presentation from AIMS Rishikesh, Dr. Suthiraj S. under Dr. Inder Kumar Sharawat. You can start to share your screen.
Amresh has done. Amresh has shared.
Okay, you can start. We can see your slides. You can put it
It's the
on
last slide. Peter, it's your last slide, huh? Yeah.
Yeah, good evening, all the respected delegates. I am Dr. Amresh Rai. I am pediatric neurology fellow from Indira Gandhi Institute of Child Health. Today, I am going to present one case. Yeah, so this is a 12-year-old male child hailing from Karnataka, informed by mother, presented with one episode of paroxysmal event, which is followed by altered sensorium. The child was apparently normal till 5 days before admission in our hospital. He was studying at 5th standard with average scholastic performance with excellence in the sports activities. Suddenly, he developed fever without any focus with passage of high color urine. On day 1, the child had recurrent episodes of vomiting immediately after feeding, containing food particle with a frequency of 4 to 5 episodes per day, not improving even after taking oral antiemetics. The fever subsided within 2 days after onset. On day 3, he developed sudden onset of diffuse cramping pain abdomen surrounding the umbilicus and the lower chest, and it was followed by 1 episode of GDCS type of convulsion in the early morning during sleep. So the child was immediately admitted in the local hospital, and on admission, the child had a poor GCS of E2, V2, and M3. Child also having hypoventilation with hypertensive bleeding on examination. So in course on examination, on course in hospital, the child was immediately intubated because of poor GCS, and lateral infusion was started because of hypertension reading, and IV levetiracetam was started as an anti-seizure prophylaxis. Within 1 hour after admission, the BP dropped to 50 percentile and was maintained on oral amlodipine. On examination, the child has sluggish dependent reflex in all the 4 limbs except ankle jerk was brisk. No meningeal signs were there. Normal tone in all 4 limbs and no organomegaly was there. The child could be successfully extubated after 2 days. And following extubation, the child developed new onset psychosis and abnormal behavior in the form of self-mutilating and aggressive behavior, some hallucination, inappropriate shouting, agitation. Although he was able to recognize his parents and he could follow commands occasionally. And he also had decreased sleep span also at that time, and it lasted for 2 days and got improved with oral antipsychotic medications and melatonin also. So on day 6, the child was evaluated for this complaint of psychosis and abnormal behavior, and he was noted to have hyponatremia with severe hyponatremia of sodium on 104 milliequivalent, along with hypokalemia. So the child was started on 3% infusion of a normal saline, along with gradual correction of hyponatremia over 9 to 10 days. So following extubation, after 2 days, he also complained of paresthesia in the form of intermittent burning sensation and pin needle sensation in the hands and feet, which lasted for approx 15 days. The child was evaluated and discharged home after 2 weeks of stay in the hospital with oral anti-seizure medication and amlodipine. And at the time of discharge, the child was completely, apparently it was normal. The child was having child was alert, with intact memory, with normal sleep and behavior. The EEG was done after 1 month of discharge, and EEG was normal, so anti-seizure medication was stopped. The gradual tapering over 1 month as part of protocol of symptomatic seizures. So the child was unable to excel the sports activity after discharge. He stood third in the long run, but before this illness, the child was standing fast in the sports activity in the school. So again, after 2 months, he got another episode of fever without focus, lasted for 1 day, which was followed by similar episodes of vomiting, pain, abdomen, and just followed by 1 episode of GDCS type of convulsion on day 3 of fever. So the child was readmitted, and the child on admission also had encephalopathy with GCS of less than 8, and also having hypertensive breathing. And the child was admitted, and child was intubated also. The following extubation, the child developed anger episodes and crying spells also. And this is treated by risperidone, and the child improved significantly within 1 to 2 days. On second day, after extubation, the child wanted to have significant hyponatremia like the previous episode, and the sodium correction was started with 3% NS like previous, and following initial reading of low serum sodium of 104. So the sodium level further worsened on the second day from 104 to 100, almost 100 millimole per liter. So after the child was shifted to ward after 7 days from the PICU, the child suddenly developed cramping pain in the limbs, extending up to the knees and elbow, getting relief by the massaging the limbs and by the caregiver, with constant burning sensation in the hands and feet. And along with that, the child also developed poor articulation of the speech. He lost the ability to properly grasp any object in the hand. He developed decreased arm swing with Parkinsonian feature, and the child had difficulty in getting up from the lying down position in the bed, and the child also had decreased facial expression. This is a family pedigree. This is the 4th issue of tertiary consanguineous married couple. No family history of similar, and family history of similar illness was there in the first issue. The first child was a 9-year-old.
Dr. Amrish, your 5 minutes are over. You may take another minute or so.
Yeah, the child actually, the child also died at 9 years of age following that similar episode of fever with vomiting with GTC type of convulsion. He was admitted with required mechanical ventilation for 7 to 8 days, and the child died at day 9 of mechanical ventilation. So child had normal birth and developmental history according to the informant. So thought of possible 3 differential in this case, which are tyrosinemia, acute intermittent porphyria, and mitochondrial complex deficiency, complex 1 deficiency. So I'm not going to this what are the points in favor and against. So on examination, the child had head circumference of 51 centimeter with the normal length and weight. Child having non-healing ulcer over the left ankle. So on examination, the child had decreased interest to surrounding with decreased facial expression, oromandibular dystonia with tongue tremor was there. Child was having rigidity in all 4 limbs, and muscle power was less than 3/5 bilaterally in the wrist and the fingers as well as. Yeah. So on examination motor system, the child had obliques detailed in all joints except ankle. Plantar was extensor bilaterally, and the sensory examination was showing intact long and short fiber sensation with intact cortical sensation. But the child was having extrapyramidal symptom in the form of resting tremor, dystonic tremor, and bradykinesia. So this is the video which is showing tongue tremor in this child. This is the showing bradykinesia. The child. And this video is showing some resting tremor in this child. So the child was having some circumduction gait on the right side. He also had some poor articulation of the speech with dysprosody. This child also had tremor.
Amrish, please wind up your new from beginning. It's 5 minutes, please.
Yeah. So this is at the serum electrolyte level. The child is day 3. The child had significant hyponatremia, which was corrected rapidly to 129 on day 4 actually. And on the child on day 3 had low serum osmolality with high urine osmolality, which was and high urine sodium, which is variety of SIADH. And what we did, and which is showing high SGOT and SGPT level, and lactate was also elevated. So we did MRI in this child. Just MRI was showing bilateral symmetrical due to hyperintensity as well as flare hyperintensity in the lentiform nucleus, along with some diffusion restriction was there. The child was treated as extrapontine demyelination, and based on the MRI and the course of the treatment and biochemical investigation, the child received steroid pulse, IV methylprednisolone for 5 days. Started on haloperidol and for dystonia, and iodine porphyrin was sent, suspecting acute porphyria, and it came as positive. So we did it.
No, I just come to the take-home message, Bella, please. Yes. Yeah.
Yes. So the take-home message is SIADH a potential complication in any patient with acute intermittent porphyria causing hyponatremia, which aggravates the altered behavior in this patient. So gradual correction of the hyponatremia should be followed to avoid extrapontine demyelination, and IV steroid pulse help in recovery in these patients. Thank you.
Dr. Raju, your comments.
Yes, madam. So any child when comes with seizures, with especially with SIADH and neuropathy, you should always consider porphyria, and with deterioration following correction of sodium, you should always consider extrapontine myelinosis, because radiologically it can mimic many things. So you should always consider these 2 conditions, even though they are very rare. So sometimes they are treatable and you can correct. Child has significantly improved with treatment. Thank you.
Thank you. Thank you. Well presented, Amrish, but you can't have 47 slides of 5 minutes, Amrish. From next time onwards, please show your slides to Raju before putting it there, please. It's for 5 minutes. It's not that we are cutting you short. We were giving time for 5 minutes. No? So thank you so much. And you get your slides there. So I'll request Dr. Vinod to give his comments. And actually, he has to leave, so he'll give his take-home messages as well. Because actually, he's in the middle of some journey. Dr. Vinod, will you make comments on this case, which was well presented by Amrish and Raju, and in your final take-home message also for the entire session, because I understand you are on the highway. So please, Dr. Vinod Skare.
Thank you very much, and apologies I could not keep my camera on. That fantastic presentation on the case. So my take-home message is, I think genetic testing is becoming the mainstay as we go forward. And on my talk specifically, I think the only take-home that I have is genetics will make us much more humble as we learn many more things that we did not know in the past. Thank you.
Thank you, Dr. Vinod. Thank you so much. And thank you very much always. Really grateful to you. And you can, thank you so much. You can ask the other experts, Juhi, and we can continue. Yeah.
Yeah. Any comments from our experts of today, Dr. Biju, Dr. Puri, and Dr. Zaveria?
No, fantastic case. And I was expecting fantastic case from Raju anyway. So I knew it would be fantastic.
Yeah, but you know, Raju, your slides and number is also fantastic, you know. So if the next time onwards, you show me actually, okay? Number of slides. We're not cutting you off, you know,
No,
it's
I
5
told to
minutes.
put only 3 videos. He has put many videos only in that.
I think yes, okay, now let's not this thing. Sangeeta, you also have something to say? Raju always, no, Raju presents wonderful, his students present wonderful cases. I really admire that. He's our alumnus again, so it's very good. So can we have comments from Dr. Sain, Sangeeta, Dr. Javeria, anybody else wants to say? Yeah.
Thanks, Amresh, for the nice case. So this is a very interesting presentation, this neuropathic crisis in acute intermittent porphyria. You rightly pointed out in your differential, like tyrosinemia type 1 also can present in a similar way. Because in tyrosinemia type 1, you have the fumarate acetoacetate hydrolase deficiency. So as a result of which you have accumulation of succinyl acetone. The succinyl acetone will reduce the activity of delta ALA dehydratase in the liver. So as a result of which you again have similar symptoms like abdominal pain and neuropathic crisis. So well worked up case and well managed case. Thank you.
Dr. Sain, Dr. Ratnapuri.
Yeah, very nicely presented, Amrish. I was going to ask, was the final diagnosis made on the urine porphobilinogen level, or was there any molecular DNA test as well?
Yeah, we did whole exome sequencing also. Whole exome sequencing was showing HMBS gene mutation, autosomal dominant. It was a pathogenic mutation, and that is a intron 10 was most probably mutated. Yes, intron 10.
Okay. Yeah, and it's again, family history can be a useful localizing tool. So based on the consanguinity, you would suspect a recessive disorder, but AIP is dominant. So we are proven wrong and humbled all the time.
We've already crossed the time. Can we have the next cases now? Only 5 minutes each, please.
Yeah.
5 minutes, one last case. Yeah.
So 2 cases are pending, one from AIIMS Rishikesh and one from Chennai, Dr. Ranjit's team. So I invite Dr. Suthiraj.
Just before that, Dr. Sain, you have come out from the clinic. Whenever you want to leave because they crossed the time, but you please give take-home message before you decide to leave. That's what I was telling them that we have to finish at 9:30. You have come out from your clinic. I understand and very grateful. If you can stay on for 10 more minutes, that'd be wonderful. But in case you have to leave, then I want a take-home message from you before you leave.
Oh, thank you so much. I will probably do my take-home message now then, and I'll try to stay on with video off.
Sure.
But I was going to say that historically, pediatric neurologists have thought of EEG, MRI, and lumbar puncture as the 3 diagnostic tools that are available to them, but sequencing is very much a part of the diagnostic toolkit. So every time you get a diagnostic consult, be that for refractory epilepsy, be that for a movement disorder, be that for neuromuscular, you have to ask, does this patient need imaging? Do they need to be sequenced? And working collaboratively with your medical geneticists to make sure the appropriate test is sent and it's sent fast, because you are the ones who are dealing with daily seizures and regression. So you have to advocate for that and understand what the test is testing for and what is not being covered by a genetic test. Yeah, I think that's my take-home message. And thanks again, Dr. Gulati, for inviting me.
Thank you so much for coming. Thank you. Do we continue?
So, if we have the case presenters here, Dr. Suthiraj or Dr. Deepti. Dr. Suthiraj is here.
Yes, ma'am. Yes, ma'am.
So Dr. Suthiraj is presenting a case. She's from AIIMS Rishikesh under the guidance of Dr. Inder Kumar Sherawat.
Is my screen visible, ma'am?
On the way. Yeah, it is. You can start.
Good evening, everyone. Today I will be presenting a case of a boy with developmental delay and epilepsy under the guidance of Dr. Inder Kumar Sherawat.
Yeah.
So,
Put it on
we
slideshow,
have-
please.
Ma'am, it is on
slide-
slideshow.
No, it is okay. We can't see it on slideshow.
Now, ma'am?
No, not yet.
I think we can continue unless you have videos there. We can continue actually.
Okay.
Okay, ma'am. So we had Master V, who is a 7-year-old boy hailing from Bijnor, UP. He presented to our OPD with complaints of right focal seizures in the form of tonic-clonic movements of the right upper limb and lower limb with twitching of the right side of the face and drooling of saliva. The first episode of seizure occurred at 1.5 months of age, and each episode of seizure lasted for around 5 to 10 minutes, followed by post-ictal drowsiness. The initial seizure frequency was around 1 episode per week, which later increased to around 5 to 6 episodes per week by around 2 years of age. Associated with this, the parents also noticed that by around 5 years of age, these seizures were precipitated by activities like bathing, washing the face, or brushing his teeth, especially when he was dealing with hot water. The child also had associated developmental delay in all domains and autistic features like lack of interest in his surroundings, decreased eye contact, or repetitive hand clapping movements and behavioral problems, with an ISA score of around 124. However, the child had no history of any significant birth asphyxia or any perinatal insult, and he was born out of a non-consanguineous marriage with no significant family history of seizures or any neurological illnesses. On examination, the child had no dysmorphic facies or any focal neurological deficits, no vision or hearing impairment, or any neurocutaneous markers. With this history,
we can't see your slides actually. It's just one slide showing. So maybe you can close and then open it again. Try that.
Hello. Sudhiraj, you can now reshare your screen.
Yeah,
Okay,
reshare it.
I have stopped your sharing. Now we can reshare your.
Okay. Actually, while she's doing, Dr. Ratna Puri had to leave. So, Dr. Ratna, can you give your take-home message?
Yes. So my take-home message for all is that we have to understand the test we are ordering, and therefore we have to get a little information about how the reporting is done. A phenotype is very important when ordering a test, otherwise you can miss the variant. And the second thing is that for variants of uncertain significance, I think we have to not just take them at face value and go through various steps to make sure that the label that we are giving to the patient is the correct one. Because once you've inappropriately labeled a patient, that label stays with the patient for life. So I think whether we are doing an exome or you're doing a genome, you need the phenotype, you need to understand what to do when, and the third is we need to learn how to interpret the report.
Thank you so much, Dr. Ratna, for joining. Thank you very much.
Thank you for a great session.
Thanks. Dr. Suthiraj, please continue, please.
Ma'am, is my screen visible now?
Yeah, it's visible. Not the slideshow, but we can see your slides.
Okay, ma'am. So with this history and examination findings, we initially kept the possibility of neurodevelopmental disorders and developmental epileptic encephalopathy like CDKL5 or STXBP1 as our first possibility, followed by structural brain malformation like tuberous sclerosis, lissencephaly, or any acquired causes like perinatal insults or hypoglycemic insults. However, the child was not having any history of any significant perinatal insult or any neurocutaneous markers on examination. We also considered the possibility of metabolic causes like cerebral creatine transporter defects or homocysteine pathway defects. However, the metabolic workup of the child was also normal. With a normal serum homocysteine level, and the creatine peak was visible in the MRS also. This is the MRI of the child, which does not show any features suggestive of any perinatal insult or any cortical malformations or a structural defect. We also did an EEG for the child, which showed bilateral symmetrical preserved background with posterior dominant alpha rhythm with frontalis muscle artifact with no abnormal slowing or fast activity or no interictal epileptic discharges. Since the child was from a very poor socioeconomic status, we were able to do a clinical exome sequencing for the child free of cost, which showed a loss of function mutation in the exon 8 of SYN1 gene, which is inherited in an X-linked fashion, causing epilepsy 1 with variable learning disabilities and behavioral disorders or intellectual developmental disorder 50. So, just a few words about SYN1 related disorders. SYN1 or
Dheeraj,
synapse.
we are not able to see your slides, but we are able to hear. So maybe you can tell us about the case.
Yeah, tell us the take-home message, beta. We're not having review of literature, and in future, everybody has to join at 7:30 and test your slides. Otherwise, you will not be allowed to present. You can't waste everybody's time like that. Huh? Okay, just give a take-home message now. Then your mentor can speak. Please give your take-home message.
My take-home message is that in a child presenting with focal seizures or development delay or autistic features and reflex seizures, we have to think of SYN1 related epilepsy. And in this child, we had treated the child with oxcarbazepine, and the child is currently seizure-free for the last 5 months.
Thank you. Your preceptor? Can your preceptor make any comment?
Good evening, ma'am. This patient had early onset behavioral changes and severe epilepsy. Usually, the truncating mutation in SYN1 gene has early onset epilepsy and severe phenotype. Although this patient had non-truncating missense mutation, but this child had severe phenotype in form of high seizure frequency.
Right. Thank you, Dr. Inder.
Can we have the next case also?
Yeah.
Thank you, Inder. And I think, people can, the students can check their slides before around 7:30 they can log in. Can we have the next case, and then we can ask everybody the comments and the take-home message from Dr. Biju and Sangeeta and Javed.
So Dr. Deepthi from Sri Ramchandra Institute, Dr. Ranjit's team. You can start to present and put it on slideshow. We can see your slides.
Good evening, everyone. I'm Dr. Deepthi. I'm going to present a case of early onset infantile drug-resistant epilepsy with a rare genetic mechanism. So our patient is a 3-month-old baby boy referred for history of multiple episodes of seizures since 1 month of age with a frequency of nearly 10 to 12 episodes per day and a duration ranging from few seconds to 2 to 3 minutes. He had multiple semiologies also like twitching of eyelids, nystagmus with vacant stare, focal tonic-clonic and multifocal clonic seizures. One of the patient videos where we can see the child is having a right-sided eye deviation with multifocal clonic movements. The seizure almost lasted for 20 seconds with a postictal irritability and cry. In the background, he was firstborn of non-consanguineous marriage. Both his parents are doctors. He had uneventful antenatal, natal, and postnatal periods. There was no family history suggestive of seizures, movement disorders, developed disorders, or any early infantile deaths. He had a mild.
I had logged in at 7:30, sir, but they did not start till 8 o'clock.
Sudhiraj, please mute yourself.
Examination, the head circumference was normal. Antefontanal was at level. There was no facial dysmorphism, no neurocutaneous markers or any obvious congenital malformations. The baby was alert, active, with a normal muscle bulk, mild hypotonia, normal power, and deep tendon reflexes were normally present. So with this history and examination findings, we kept a differential diagnosis of structural epilepsy like cortical malformations, neurometabolic disorders like mitochondrial, cerebral creatine deficiency disorders, pyridoxine-dependent epilepsy, pyridoxal phosphate responsive epilepsy, or biotinidase deficiency disorders, and last but not the least, the genetic epilepsy syndromes. So on MRI, we could just see a mild prominence of CSF spaces in bilateral frontal convexities, suggesting either benign enlargement of subarachnoid spaces or a mild cerebral atrophy. He had a normal MRS. This is a ictal EEG record of this baby. Here the baby had suddenly woken up from the sleep, then went into a behavioral arrest. And we can see a change in background quality. There was a left-sided eye deviation. Correspondingly, on the EEG, we can see a buildup on right side, followed by spike wave discharges again on the right side in the frontocentral and parietal regions, which then spread to the left parietal region as well. This EEG was suggestive of a focal onset epilepsy. His neuroimaging was normal, so possible genetic etiology was considered. His blood metabolic workup was negative. So we sent for a whole exome sequencing with mitochondrial gene panel. For the seizure management, a trial of high-dose vitamins was given like pyridoxine, pyridoxal phosphate, folinic acid, and biotin, but there was no improvement in the seizure frequency. Levetiracetam, phenobarbital were optimized, and oxcarbazepine was added in view of focal onset of seizures. While we were on the escalation dose of oxcarbazepine, we got the whole exome sequencing reports. And to our surprise, it showed a heterozygous missense variant in exon 9 of the CDKL5 gene. It causes a DEE2 and is inherited in an X-linked dominant pattern. Since this mutation is mostly seen in girls and our patient was a baby boy, we had not thought of it as a potential genetic etiology in our case. Coming to the review of literature.
Can you please come to your take-home message slide? 25 slides are not possible in 5 minutes, beta. Everybody is given 5 minutes, no? Please just come to your last. Otherwise, we can have only 2 cases, 15 minutes each, but many people are there. Give the take-home message. Yeah.
Just the CDKL5 related DEE should be considered in patients of both genders with early onset epilepsy, developmental delay, and microcephaly and hypertonia.
Thank you, Ranjit.
Yeah. Good evening, everyone. Thanks for giving this opportunity to present.
Stop slide share na, ताकि photo दिखेगा Ranjit का.
So when we said the genetic testing, I didn't think of CDKL5 to be honest, because we always thought CDKL5 can happen only in girls. So this was the first case I saw. There are only 45 case reports around the world. So then actually the mother is a pediatrician. She was asking about the prognosis. So I think there is no time here. So if there is a way we can determine the degree of post-zygotic mosaicism, that may help us in understanding the severity of the disease phenotype. So we tried ketogenic diet. There is a partial success, although ganoxolone, which is supposed to work well for CDKL5, is currently not available in India. Thanks again. Yeah.
Thank you, Dr.
You're muted, Juhi.
Yeah, if I may ask a quick question regarding the previous case of reflex epilepsy SIN1 positive to our experts, including Dr. Ranjit, that giving a clobazam, oral clobazam before taking a bath or before exposure to that stimulus, is that an idea for these reflex epilepsies?
Yeah, so we do use in some situations. Sometimes, like if they don't have any non-reflex seizures, otherwise unprovoked seizures, sometimes you require daily conventional anti-seizure medication. If all these seizures were only reflex, you either try to avoid the reflex as much as possible, and sometimes 30 minutes before we give clobazam. It has worked in few cases. And that SIN1 with a very classical case, I have seen at Sick Kids also. Whenever you have a bathing epilepsy, suspect SIN1. So I actually put in the chat box when she was presenting.
I noticed that. So you are the quiz master anyway for us. Dr. Biju?
I agree. Hot water epilepsy and SIN1, it's a very good connection. And it's common in India and Asian countries, isn't it? Because we don't see much in the West. I only have one patient and works well on oxcarbazepine and also using tepid water, not hot water. Preventing the reflex also works. But there was no. But this particular child was quite severe phenotype, with severe behavior and social communication issues. But the child which I look after, there are no behavior issues. And my understanding is that some of these children don't even need medication, isn't it?
Any comment, Dr. Ranjit, about the need of daily medications?
We had a patient who was actually getting evaluated in a pre-surgical for pre-surgical evaluation. So they can have unprovoked seizures. They can have other epilepsy phenotypes in addition to the reflex. So if they have that kind of a scenario, they do require regular anti-seizure medication actually. And toothbrushing was there in my case, which I saw at Toronto. There was a history of toothbrushing seizure. Yeah.
Were the Asian children or?
I think that one was a native Canadian.
Okay. Oh.
Okay. I think we're done with the cases, ma'am. And if we have any comments from our expert panelists today, and take messages, Dr. Biju.
No, I think, it's pretty clear that, whole genome, whole exome sequencing is the way to go, quite powerful tool. But I think I also feel that, some of these advances have been rushed through that, like at least in the last 10 years, we never had any chance to come up with the ideal pathways and protocols to, proper SOPs to approach these conditions. Like there are still situations where we do a whole host of neurometabolic investigations, spends a lot of money and time, and then when you hit with a blank wall, then we go for whole genome sequencing. Because there is still no guidelines and protocols on like when do you go to whole genome sequencing. At the same time, there are some clinicians who just blanket go for whole genome sequencing straight away. So there must be, so it's not very regulated at the moment. And those are the challenges and limitations when it comes to genetic sequencing. And Dr. Ratna highlighted all those things. I suppose in terms of advances, I think the more understanding of epigenetic mechanisms, interpreting genetics in terms of the epigenetic mechanisms, I'm sure it will come. Integration with transcriptomics, combining it with RNA sequencing, functional studies, and then, AI and machine learning already has positively disrupted the interpretation of whole genome sequencing data. A good example was the hypomyelination case, and hypomyelination sometimes can be very tricky if it is just hypomyelination. To come to an answer just using whole genome sequencing, because there could be like interplay of multiple gene mutations with hypomyelination. So I think the pediatric neurologists will still have a job. So and I think will have a major role to play as well. So it's all about judicious use of whole genome sequencing.
Yeah, but that phenotyping is very important, and without that, you are totally lost. And this is actually going to be continued, I think. And so that is why this talk today, because it's still, we are all very perplexed many times in this situation, and the cost continues to be high. And although for that, Vinod was definitely mentioning that your cost per day for NICU care was high, but in hospitals like ours where you don't have any cost. Because being in the government setting, for the patient, for the for staying of the NICU per se. So here, when you have to take out the money, it becomes this thing. So it is there. So I think we have to be very cautious in our approach. And I think it was a wonderful session. And wonderful presentations from our early career. Just a request for all of them to just log in early and try out the slides. And please keep the slides not more than 10. You actually know it's 5 minutes. Other from next time we have only 2 people presenting. So you can't just go on stretching right now. Thank you so much for everyone for joining. Mahesh, you want to say anything? Juhi, you want to say anything?
Nothing, ma'am. It was a really nice talk, and it was nice to know about that new entity, blended genome and exome testing.
Yeah.
Think it more and more in future.
Yeah, that's good. Thank you. Thank you, Dr. Biju. Thank you, everyone. Yeah, and Asmita is showing the conference. Well, all the registration, abstracts, and symposia proposals and on, you can scan the QR code and do it. Yeah, hoping to see you next year in New Delhi. Thank you so much. And we come next week back again because we have the new year coming up. So we'll have next week something whole on neuroradiology by Dr. Kish next Wednesday. Audio नहीं आ रहा है अस्मिता.
Hello.
So your audio was not coming of the video, but I'm saying next week we have the session with Dr. Kish Mankad talking about the neuroradiology aspects because we will be closing down near the New Year Eve because everybody will be on holiday, right? So your video was not coming, but anyway you played it in the beginning, so you can play it again in any case for whoever is there.
Yes, ma'am.
Any issue, Asmita? You want us to leave it?